Right now, millions of people are walking into clinics to get these, rejuvenation treatments with lasers.
Yeah, it's become incredibly common.
It has. And I think for the most part, you assume the process is basically like a high-tech facial. It's marketed to you as this quick, painless way to just tighten up the tissue.
Right, just erase some wrinkles, maybe tighten things up, and you're good to go.
Exactly. But what patients rarely realize, and what we're really getting into today, is that these light wands are fundamentally restructuring the microscopic architecture of their bodies.
Oh, without a doubt.
Like they're literally vaporizing cells and leaving behind this permanent altered blueprint that future surgeons are actually going to have to navigate.
Yeah, it represents a massive shift in how we interact with human anatomy, honestly. We tend to view these devices merely as cosmetic tools.
It's just casual upkeep.
Right, casual upkeep. But beneath the surface, I mean, they are incredibly powerful surgical instruments. They initiate these intense cascading biological reactions.
The cellular landscape is just never the same once they're used.
Exactly.
And that stark disconnect between, casual clinic marketing and the actual biological reality. That's exactly why we were doing this deep dive today.
It's such a vital topic for anyone considering these procedures.
It really is. So we have a fascinating stack of medical sources to go through for you today. We're looking at a comprehensive review of laser physics from the International Society for Gynecologic Endoscopy.
The ISGE, right?
Right. And we also have adverse event reports from NICE, which is the UK's health guidance body, and this absolutely gripping surgical case report.
That case report is wild.
It is. So our goal here is to really understand the microscopic mechanics of these tools, right? Like the incredibly fine line between a laser healing tissue and permanently harming it.
Which is a razor-thin line.
It really is. And most importantly, we want to answer one highly specific, crucial question today.
The core focus.
Exactly. The focus for today's deep dive is, can previous laser treatments physically alter surgical tissue planes? And what happens when a surgeon has to operate on that remodeled tissue years later?
Yeah, to understand the complications that arise in an operating room, say a decade down the line, we really first have to understand the fundamental physics of the technology.
Right. We have to start with the basics.
Right. So the word a laser is actually an acronym.
But I always forget that it stands for light amplification by the stimulated emission of radiation, right?
You got it. That's exactly it.
Okay, let's unpack this for a second because I know the physics sound intimidating, but the ISGE text actually breaks it down beautifully.
They do a great job making it accessible.
Yeah. So to grasp what the laser is doing, you have to picture an atom with its surrounding electrons.
Right, and those electrons occupy what we call resting orbits.
But when you pump energy into that atom, like, say, a jolt of electricity, those electrons jump up to a higher, unstable orbit.
Exactly, but they can't maintain that state forever. It's unstable.
Right.
So when those electrons inevitably drop back down to their original resting orbit, they release a tiny, tiny package of energy.
And that package is a photon,
Mm-hmm.
right? Like a single particle of light.
Yes. And in physics, we call that spontaneous emission.
Okay, so if we think about a normal light bulb in a lamp, that bulb is emitting photons through spontaneous emission.
Right, just throwing light everywhere.
Yeah, it's chaotic. I was thinking it's like a massive crowd of people pouring out of a stadium after a concert.
Oh, that's a perfect analogy.
Right. Like they're walking in every direction. They're moving at different speeds, totally out of phase with each other. The energy is just entirely scattered.
Right, but a laser operates on a totally different principle. It uses stimulated emission.
Simulated, okay.
So in that scenario, a photon interacts with an already excited atom, and it forces it to release a second identical photon.
Oh, so the reaction cascades.
Exactly. It creates a chain reaction.
So instead of that chaotic, scattered crowd from the concert, you suddenly create an army.
A very organized army.
Right. The light becomes, the text calls it collimated, meaning it travels in a tight straight line without spreading out.
Yes.
And it is coherent, meaning the light waves are marching perfectly in lockstep. And it's monochromatic, meaning it's just one uniform color.
An army of light marching in lockstep.
It sounds so sci-fi when you put it like that.
It really does. But that uniformity is what transforms just regular light into a surgical scalpel.
Right.
Surgeons can actually select different, armies of light based on the specific wavelength they need for a procedure.
Because different physical mediums generate different properties, right?
Exactly. The argon laser, for instance, emits a blue-green light at a wavelength of 514 nanometers.
Okay.
And that specific color is highly absorbed by hemoglobin.
meaning it acts kind of like a heat-seeking missile for the pigment and red blood cells,
You got it.
which makes it perfect for treating highly vascular conditions like endometriosis.
Precisely. Then you have the NdYAG laser, which operates at 164 nanometers.
And that beam is totally invisible, right?
Yes, invisible, and it penetrates very deep into the tissue. We're talking roughly 3 to 4 millimeters.
Wow, okay.
But because it ignores water and fluids, it is an essential tool for hysteroscopic surgeries where a doctor is, operating inside a fluid-filled uterus.
That makes sense. But the real heavy hitter in these sources, particularly when we talk about treating conditions like genitourinary syndrome of menopause or GSM, is the CO2 laser.
Oh, absolutely. The CO2 laser is everywhere right now.
Yeah, and this one operates way out at 10,800 nanometers. Again, it's invisible, so doctors actually have to use a little red helium neon pointer just to see where they are aiming the device.
Like a laser sight.
Exactly.
Right.
And unlike the N.YAG, the CO2 laser is fiercely absorbed by water.
And considering human tissue is, well, mostly water, its effect on our biology is incredibly dramatic.
Yeah, I bet.
When the CO2 laser hits the tissue, its depth of penetration is extremely shallow, usually less than 1 millimeter.
But it packs a punch in that 1 millimeter.
Oh, a massive punch. The light targets the intracellular water and instantly boils it. The water just flashes into steam, and the cell literally explodes.
It explodes.
It is instantaneous vaporization.
Okay, hold on, because I need to challenge the underlying logic of this treatment here.
Sure.
Because for a condition like GSM, as you're listening, you might know a patient is dealing with vaginal tissue that has become incredibly thin, dry, and fragile, right? Usually due to a lack of estrogen.
Right. It's very vulnerable tissue.
So how does hitting that already vulnerable tissue with a laser, literally boiling the water inside the cells and exploding them, make anything better?
I know, it sounds counterintuitive.
Conceptually, that sounds like throwing gasoline on a fire to me.
It sounds incredibly violent. And at a microscopic level, I mean, it is. But the operating principle here is controlled thermal injury.
Controlled injury.
Yes. The goal isn't to destroy the organ. The goal is to trigger the body's emergency repair protocols.
Oh, okay.
You are essentially tricking the body into thinking there is a catastrophic wound that requires immediate structural reinforcement.
And here's where it gets really interesting, because the body's repair mechanism actually kicks in.
It does. When that tissue vaporizes, it sets off a biological alarm bell. Fibroblasts, which are the specialized cells responsible for building our structural framework, they just flood the targeted area.
And they initiate a process called neocollagenesis, right?
Yeah,
Frantically laying down fresh collagen fibers.
exactly. And simultaneously, neovascularization occurs. It starts sprouting new blood vessels to supply that wounded area with oxygen and nutrients.
So the end result is that the body basically replaces the thin, atrophied tissue with a completely remodeled, thicker, and more elastic structure.
Right.
It's essentially a medical micro-welder. You purposefully cause a tiny amount of damage to force regeneration.
But, and this is a massive but, because we are dealing with boiling cellular water and exploding cells, the margin for error is razor thin.
Which makes a statement I found in the sources deeply, deeply concerning.
Oh, the clinic marketing.
Yes. A UK women's health clinic, in their promotional material for CO2 laser treatments, claims that because the heat generated on the vaginal wall doesn't exceed 45 to 16 degrees Celsius,
Great.
they say the possibility of thermal damage is illusory.
It's just wild that they published that.
Right. They are boldly arguing that severe risks are purely a matter of practitioner error, and they are completely dismissing the fundamental nature of the technology itself.
Yeah, that is an incredibly dangerous oversimplification of laser physics. I mean, it treats a high-powered surgical tool like a household heating pad with a maximum temperature setting.
Right, like you can just set it to medium fall asleep.
Exactly. The interaction between light energy and human biology is vastly more complex than just taking a simple thermometer reading on the surface of the tissue.
Because if the risk of thermal damage is just an illusion, it makes it literally impossible to explain the adverse event reports from NICE.
Right.
We are looking at documented cases in a government database detailing third-degree burns and permanent disfigurement from these exact procedures.
The ISGE review directly contradicts that clinic's marketing. The severity of tissue damage relies on a triad of parameters.
Okay, what are they?
Wattage, which is the raw power. Spot size, which dictates how tightly concentrated that power is. And time, how long the beam rests on a single millimeter of tissue.
So if a doctor uses a tiny spot size, unexpectedly cranking up the power density,
Right.
or Just holds their hand still for a fraction of a second too long.
The thermal energy has nowhere to go but deeper into the tissue.
Right.
The anatomy of a laser burn actually has 3 distinct zones. The epicenter is the zone of vaporization. That is the literal crater where the tissue has been completely converted into a plume of smoke.
It's just missing tissue at that point.
Exactly. But immediately surrounding that crater is the second zone, and this is where the danger really lies. It's the fixed zone of stromal necrosis.
Stromal necrosis.
Yeah, this tissue didn't absorb enough energy to vaporize, but it absorbed enough heat to boil the proteins and kill the cells. It is dead, coagulated tissue.
Wow.
And only below that necrotic layer do you find the third zone of reversible injury, the tissue that just got warm enough to stimulate the fibroblasts without dying.
So practitioner error, or even just slight anatomical variations in a patient's tissue thickness, could easily cause that dead zone to expand much deeper than intended.
Very easily.
Let's look at the real-world consequences of that in the ANSAFE reports. There's a case of a 65-year-old woman who underwent laser therapy and resumed intercourse a few weeks later.
Yeah, that one is rough.
She suffered severe vaginal lacerations, heavy bleeding, and eventually developed a foreshortened vaginal canal with severe tissue fibrosis.
We really need to examine that word carefully, fibrosis.
Okay.
Because when thermal injury penetrates too deeply, the body's repair mechanism shifts from orderly regeneration to sheer panic.
That's freaking out.
Exactly. It realizes its structural integrity is severely compromised. So instead of neatly organizing new collagen fibers to restore elasticity, it haphazardly dumps massive amounts of dense, rigid scar tissue just to bridge the gap as quickly as possible.
It's a biological emergency patch job.
That's a great way to describe it.
Another patient in the NIAS report developed a, quote, crescent-shaped fibrous band right in the middle of the vaginal canal.
A physical stricture.
Yeah, it was acting like a roadblock, partially obstructing the anatomy. And a third woman experienced extreme spasms in her levator anisaili, the pelvic floor muscles, along with severe anterior wall scarring.
See, these are not temporary side effects like localized swelling or a rash. These are permanent architectural transformation.
The blueprints are changing.
The elasticity, the natural stretch and give of the healthy tissue is permanently replaced by unforgiving, leather-like scar tissue.
And if the body is laying down leathery scar tissue and building these fibrous bands, we have to look past the immediate aftermath. We have to confront the core focus of today's deep dive.
Right, the surgical tissue planes.
Exactly. Can previous laser treatments physically alter surgical tissue planes? If a patient has this procedure at 45, and then at 55 they need a routine hysterectomy or maybe a bladder sling, what is the surgeon actually looking at when they open them up?
The anatomical landscape is just completely disrupted. Surgeons rely heavily on natural tissue planes.
Right.
These are the delicate avascular layers of connective tissue that separate our internal organs. They act as the body's natural boundaries, providing these safe pathways for surgical instruments.
I always think of healthy tissue planes like the layers of an onion.
That's a perfect image for it.
In a healthy patient, a surgeon can gently slide an instrument, or even just their finger, between those layers and effortlessly peel them apart.
Exactly.
The bladder just separates cleanly from the vaginal wall.
Right.
But after severe thermal necrosis and the resulting panic-induced fibrosis that you mentioned, it's as if someone injected industrial superglue between those onion layers.
The clinical term for that is obliterated cleavage planes.
Obliterated. Wow.
Yeah. The organs literally fuse together into one rigid, fibrotic mass. The surgical textbooks no longer apply because the predictable landmarks are just gone.
And the sources specifically mention this when discussing the surgical management of severe vaginal stenosis, which is that narrowing caused by the scarring.
Yes.
The text states, the scarring process of the stenosis limits the surgeon's abilities to utilize local tissues in the revision repair. So the surgeon gets in there, looks at this superglued mass, and realizes they can't even use the nearby tissue to fix the problem.
It is entirely compromised. It lacks a normal blood supply and is incredibly inflexible.
So what do?
Well, surgeons are often forced to harvest substitution grafts.
Meaning taking tissue from somewhere else.
Exactly, taking tissue from entirely different parts of the body, like the buccal mucosa, which is from the inside of the cheek, just to reconstruct the pelvic area, because the local laser-treated tissue is surgically useless.
That is intense. And to truly grasp the mechanical nightmare of operating on these obliterated tissue planes, we really have to examine the remarkable case report from Cancer Reports.
This case is absolutely fascinating.
Now, a quick caveat as you're listening. The extreme fibrosis in this particular patient was caused by pelvic radiation for cancer, not a cosmetic CO2 laser. But the experts highlight that the physical dilemma on the operating table, the fused, bloodless, superglued tissue, is identical regardless of the energy source.
Right, the catalyst for the damage was different, but the architectural devastation is exactly the same.
Exactly. So the patient is a 68-year-old woman with a history of endometrial cancer. She previously had a hysterectomy and intense pelvic radiotherapy,
And radiation is notorious for causing profound ischemia,
which means
essentially choking off the blood supply and leaving behind this deep wooden fibrosis.
so she develops a small recurrence of the cancer at the top of the vaginal vault. The surgical team decides to perform a robotic partial colpectomy, carefully removing that specific section.
Right.
But when the surgeon goes in with the robotic arms, the anatomy is unrecognizable. The report notes the dissection between the bladder and vagina was, quote, made complex by radiation-induced fibrosis.
And you have to understand, complex is a polite medical term for highly dangerous.
Right.
When a surgeon tries to separate the bladder from the vaginal wall, and those tissues are fibrotically cemented together, the mechanical tension required to pry them apart puts the organs at extreme risk of tearing.
Which is exactly what happened here. Despite the precision of the robotic instruments, the sheer force needed to navigate that superglue resulted in a 1-centimeter tear directly into the patient's bladder.
It's terrifying.
They caught it immediately, thankfully. They stitched it up during the surgery and tested it, and mechanically it looks secure.
But fibrotic tissue has a terrible blood supply. It does not heal like normal vascularized tissue.
Right.
The stitches might hold mechanically on day one, but the tissue itself fails to knit together.
And that's what we see. A week after she goes home, she starts leaking urine constantly.
The stitches failed.
They failed. She developed a vesicovaginal fistula, or a VVF. It's an 11-millimeter open tunnel connecting her bladder directly to her vagina.
It's a devastating outcome.
This is the exact catastrophic hazard that altered tissue planes pose. When those natural boundaries are obliterated by energy-induced scarring, routine dissections turn into high-stakes minefields where adjacent organs are just incredibly vulnerable.
And this patient is now facing a massive complication. Spontaneous healing isn't happening.
Right.
Catheterization doesn't work. And her overall health profile complicates everything. She is morbidly obese, diabetic, and to top it off, she develops a pulmonary embolism, blood clots in her lungs.
So a massive invasive abdominal surgery to try and re-sew that fistula is entirely off the table.
Oh, completely. Her body wouldn't survive the trauma or the anesthesia.
The multidisciplinary team is out of conventional surgical options. And this is where the story takes a wildly paradoxical turn.
I love this part.
To fix a massive hole in tissue that was essentially destroyed by energy-based fibrosis, they decide to use a laser.
It feels like a massive contradiction, doesn't it?
It really does.
But it perfectly highlights how highly variable light-based technology can be. They did not pull out an ablative CO2 laser.
Right. No exploding cells this time.
Exactly. The last thing they wanted was another steam explosion or more thermal necrosis. They utilized a non-ablative Leonardo dual-diode laser.
Okay, wait. I need you to walk me through the biology here.
Sure.
Because we are talking about an 11-millimeter tunnel between two organs. That is a massive gap in surgical terms.
Huge.
How does shining a low-power laser at the edges of a hole tell the body to bridge that physical distance? It feels a bit like magic.
It's not magic, it's photobiomodulation, or PBM.
PBM.
Right. And it all comes down to the specific wavelengths and the power settings. This dual diode laser operates at 980 nanometers and 1470 nanometers.
Okay.
Crucially, they dialed the power down to a mere 7 watts.
Which is very low.
Very low. For context, surgeons easily use 20 to 30 watts to actively cut through tissue. They also used it in a pulsed mode, giving the tissue vital fractions of a second to cool down between flashes.
So they are gently tapping the cells with light, avoiding heat accumulation entirely. But how does that close a hole?
Well, the light energy at those specific wavelengths penetrates deep into the tissue and is absorbed directly by the mitochondria, the powerhouses inside the cells.
Right, high school biology coming back.
Exactly. This absorption triggers a massive upregulation of cellular energy called ATP.
So it's basically feeding the cells a massive energy drink.
Essentially, yes. That extra energy stimulates local blood flow, bringing oxygen and nutrients to a tissue that was previously starved of it.
Okay.
More importantly, it kicks the fibroblasts into high gear, but without the panic response we saw earlier.
Right, because there's no boiling water or burning.
Precisely. Instead of dumping rigid scar tissue, the fibroblasts start carefully constructing a healthy biological scaffold of collagen across the fistula. It modulates the cellular environment to regenerate rather than scar.
It's incredible. So the medical team applied this diode laser to the fistula once a month for 3 months. It was a totally painless outpatient procedure lasting just a few minutes per session. And the results are staggering. After the third session, they performed a cystography, filling the bladder with contrast dye to check for leaks. The 11-millimeter fistula had completely, seamlessly closed. No surgery required.
It is a phenomenal outcome. The very concept we associate with causing tissue damage, laser energy, was recalibrated to act as a cellular catalyst, coaxing the body to reconstruct a devastating defect.
It's such a wild paradox. And here's where it gets really interesting for anyone paying attention to the future of medicine. Lasers are awe-inspiring.
They truly are.
They can tighten tissue, they can stimulate profound natural healing, and they can coax an impossible wound into sealing itself. But they are not harmless flashlights. They leave a permanent microscopic footprint.
Yes. If the parameters are pushed too far, they fundamentally alter the body's internal blueprints.
Right.
They replace healthy, sliding layers of tissue with rigid, superglued masses, permanently destroying the natural cleavage planes.
And right now, fractional CO2 lasers for vaginal rejuvenation are becoming as common and normalized as grabbing a coffee. Clinics market them as quick, easy upkeep.
And millions of patients are undergoing these procedures.
Millions. They're accumulating these microscopic changes layer by layer, year by year.
Which forces us to look ahead at a very practical, logistical crisis for the medical field.
Yeah.
If we have an entire generation of patients whose internal tissue planes are being quietly, permanently remodeled by thermal lasers today, what happens to surgical training tomorrow?
That is the million-dollar question.
We teach medical students and residents how to navigate human anatomy based on predictable, natural tissue planes. If those planes no longer exist in a massive portion of the population, we might literally have to rewrite the anatomical textbooks and invent entirely new surgical techniques just to safely navigate a generation of superglued anatomy.
The map of the human body is changing, and we are using light to redraw the borders. Such a fascinating topic. Thanks for exploring the new landscape with us on this deep dive.